This
Hi,
conference will now be recorded.
hi everyone. Good afternoon. We are going. I'm representing eJournal Committee from American Society of Cytopathology. Today we are going to discuss about our article titled "Touch Preparation for Rapid On-Site Evaluation of Renal Mass Biopsies: Concordance Rate, Pearls, and Pitfalls." This article was published in September and October issue of 2020 in Journal of American Society of Cytopathology. I am Sukriti Upadhyay Baskara, current cytopathology fellow at University of Pittsburgh Medical Center, Pittsburgh, Pennsylvania. I do not have any disclosure. The objectives of my presentation today is to discuss the clinical indications of percutaneous core needle biopsy of renal masses, assess the utility of rapid on-site evaluation with touch preparations of core biopsy, discuss the concordance rate of rapid on-site evaluation to that of final diagnosis of core needle biopsy of those renal masses, and identify the common pitfalls in the touch preparations of core needle biopsies. So, talking about the introduction, renal cell carcinoma is the most common clinically presented renal mass. With the wide application of radiology, detection of renal masses have significantly increased. Clinically, small renal masses are defined as a size of 4 centimeter or smaller, whether solid or complex cystic masses. Standard treatment has been always surgical for these small renal masses, which is either treated by partial or complete nephrectomy. The problem lies in preoperative misclassification, which are either classified as malignant preoperatively based on the imaging findings. This leads to surgical removal of many benign renal masses. This raises the current need of better triaging system for these small renal masses which are detected by imaging. One of the better triaging mechanism can be core needle biopsies. Core needle biopsies helps reveal the nature of these renal masses. It also further helps in deciding the malignant potential of the renal masses and grade the diagnosed malignant renal tumors. And it can be also the only biopsies performed prior to the ablation therapy and can be used in the documentation or subsequent testing if needed in the future. However, there are certain challenges. Biopsies of small renal masses are still not a standard practice despite the proven benefits. In a recent survey, many urologists commented that the core needle biopsies do not change the management option of small renal masses. And another problem which has been published in the literature is the high false negative and the non-diagnostic result. Also, the evidence or the literature of the rapid on-site evaluation for these small core needle biopsies are lacking because in general these renal biopsies do not happens too often and there are not many published literature. In this study, percutaneous core needle biopsy of renal mass lesions and rapid on-site evaluation using touch preparations were retrospectively retrieved to assess the concordance rate of rows with final diagnosis in core needle biopsies. The authors also describe the features that may help identify commonly encountered renal lesions on cytology preparations. Talking about the materials and methods, this study was conducted in University of California, Irvine Medical Center. Percutaneous core needle biopsy of renal mass with rows using touch preparations were retrieved from the institutional database after approval from their institutional IRB. All rapid on-site evaluation slides were prepared using DiffQuick, and the core needle biopsies were fixed with formalin and processed as routine. Core needle biopsies, final diagnosis, and Rose interpretation, including adequacy with or without a preliminary diagnosis, were recorded from the pathology electronic system, which is COPATH. If multiple rapid on-site evaluation were done, the highest level of abnormality was used for the analysis. The rapid on-site evaluation interpretations were divided into the following categories: malignant, positive for neoplasm, atypical. Atypical included one of the following categories, either atypical, lesional, or adequate, not otherwise specified, and negative and unsatisfactory. Whenever the rapid on-site evaluation was called malignant positive for neoplasm and the core needle biopsy was either malignant or benign neoplasm, it was called concordant. If the rapid on-site evaluation was negative or unsatisfactory and the core needle biopsy final diagnosis was negative, it was called concordant. All other results were classified as discordant. DiffQuick stained touch prep slides were available in all cases. Cases with discrepant results between rows and final diagnosis were retrospectively reviewed by a cytopathologist and a cytopathology fellow and were described. Talking about the findings, there were 165 cases in total that were included in this study, out of which 60 were female and 105 were males. The median age was of 64 years and the age range was 28 to 87 years. 81 of the renal masses were of left side, 82 were of right side, and 2 kidney masses were of unspecified laterality. The percutaneous renal masses were either done by CT guidance in 124 cases and ultrasound guidance in 41 cases. They were able to give a specific diagnosis in the final core needle biopsy in 136 cases, or 82.4%, out of which the majority, or 68.5%, were that of renal cell carcinomas. The benign neoplasms are 8.5% of cases. Urothelial carcinomas was 3.6% of cases. Metastatic carcinoma was 1.2% of cases, and lymphoma was 0.6%. There were 8 cases, or 4.8%, which were classified as indeterminate, out of which 2 cases were positive for oncocytic neoplasm, 2 suspicious for renal cell carcinoma, and 4 atypical. 21 cases, or 12.7% cases, were negative for tumor in the final diagnosis. So this is the first table included in the study, which depicts the concordance rate between the rows and the core needle biopsy diagnosis of the renal masses. In the rows, you can see the core needle biopsy diagnosis, which comprised of the 4 diagnostic criteria, 4 diagnostic terms: malignant, neoplasm, atypical, and negative. In the columns, there are the diagnostic criteria terms for touch prep or Rose interpretation, and it included malignant, neoplasm, atypical, lesional, or adequate NOS, negative, and unsatisfactory. The cases that are highlighted in blue colors are the concordant cases. The cases that are highlighted in brown are the discordant cases. As you can see, most of the cases are highlighted in blue. So the concordant cases counted for total of 87.3% of the cases, and the discordant cases encountered for total of 12.7% of the cases, are 21 cases. I will go in detail in these 21 cases, but before that, out of the total malignant cases, most of the cases were categorized into atypical, lesional, or adequate NOS category in the Rose interpretation, which is a significant finding of this study. So talking about the discordant cases, 14 of the cases were undercalled in this study out of the total 21 cases in the rapid on-site evaluation. The most frequent diagnosis for those cases which were undercalled was that of the clear cell renal cell carcinoma, and they were either called unsatisfactory or negative in the rapid on-site evaluation. The most common cause of discrepancy was the sampling error, where there was no tumor cells present on the touch preparation, or either very rare naked nuclei or rare naked nuclei were present in a prominent vacuolated background. The other frequent cause of discrepancy was the rare tumor cells present, and whenever they were present, it was of very low-grade nuclei with an abundant vacuolated cytoplasm in a prominent vacuolated background. The only case that was misinterpreted was a case of an oncocytoma with no severe atypia mimicking proximal tubular cells. And the most common confounding factor that they described that was a reason for undercalling for these 14 cases is the renal tubular cells, as you can see in this column here. So in this image, the author describes the different finding. In the first image, you can see the proximal tubular cells. They have abundant amount of cytoplasm with no discernible cell border. The nuclei are round to oval in shape with no prominent nucleoli. In the inset, you can see a focus of distal tubular cells with round to oval nuclei, scant cytoplasm, and again, no prominent nucleoli. But if you compare them with the proximal tubular cells, they do have a very scant cytoplasm. Again, in B, this is an image from proximal tubular cells. In the image C, you are seeing the image of a urothelial cells with abundant cytoplasm and a vacuolated cells. In the inset is a cell of a Sarcariform cells, and D is the image of inflammatory cells. Uh, Talking about the causes of overcalling in the rows, there were 7 cases which were overcalled in the rows, and out of which the core needle the rapid on-site evaluation, the most commonly was called atypical. 2 of them were called adequate, not otherwise specified, and one of them was called lesional. The cause of discrepancy for the overcalling was misinterpretation for 6 of them and sampling error for 1. In the sampling error, the tumor cells was only present on touch preparation but not on core biopsy. However, the repeat biopsy was positive. The other misinterpretation was either with the presence of the inflammatory cells or the urothelial cells or the renal tubular cells or the macrophages or the endothelial cells. So this image, in the first image, is the image of a renal cell carcinoma. It is abundantly cellular. You can see the vacuolated background and some naked nuclei in the background. Again, the cells are round to oval with some anisonucleosis. In the second image, also you can see the vacuolated background with abundant naked nuclei, crisp cell border, and mild anisonucleosis and binucleation. Third image is the image of a papillary renal cell carcinoma. You can see anisonucleosis, oncocytoid to plasmacytoid cell population, and fibrovascular core can be appreciated probably here. In the third image is a case of a chromovorm renal cell carcinoma. You can see how cellular this is with an oncocytoid, abundant cytoplasm. In the inset, you can see the cells has a voluminous, large amount of cytoplasm with a perinuclear halo, round to oval nuclei, anisonucleosis. There is some binucleation as well. So talking about the discussion, as we all know, core needle biopsy and fine needle aspiration has been used for decades now, but the merits of core needle biopsy and fine needle aspiration for renal masses has been debated over years, basically due to the high false negative and non-diagnostic rate. Reported non-diagnostic rate ranges from 0 to 23% in a recent meta-analysis. In this study, the non-diagnostic rate was 12.7%, but we are not clear how many actually represented the false negative due to lack of long-term follow-up study in this study. This study represents one of the rare studies assessing the accuracy of the rapid on-site evaluation in the core needle biopsy of renal mass lesions. As I have already explained in the beginning of my talk, that there are not many literature published which talks about the efficacy of rapid on-site evaluation of core needle biopsy of renal masses due to the very low volume of these cases occurring in general. So one of the other significant finding of this study was the concordance rate between the rapid on-site evaluation and the final core needle biopsies was high at 87.3%. They found that accurate feedback during rapid on-site evaluation will help improve the yield of the biopsy. When compared with the Bookhout and et al. Also found whenever the touch prep and core needle biopsy was combined, it had a very high adequacy rate than fine needle aspiration biopsy, in their study, they had 209 cases, and they performed both the fine needle aspiration as well as touch prep and core needle biopsy. However, in this study, the authors did not include the fine needle aspiration biopsies because they do not perform fine needle aspiration biopsy routinely at their institution. Other difference from the study of Buchhout et al. To this study is the authors considered atypical lesional adequate as concordant in this study because they are essentially the rapid on-site interpretations which are basically done for the adequacy evaluations. As we all know, renal cytology is challenging as they are not commonly biopsied or aspirated. And the other, there is a diverse morphology of various renal tumors, basically the low-grade tumors, which are scan tumor, which are very low cellularity in begin with. One of the another finding of our this study was also the scan tumor cellularity and the sampling error, which was the most common cause of undercalling during the rapid on-site evaluation. Another confounding factors like benign renal tubular cells, specifically the proximal renal tubular cells, was significant challenge in assessing the renal cytology specimens. The cellularity of chromophobe renal cell carcinoma and oncocytoma was found to be significantly higher than the benign renal sampling in this study. But they also found a minority of the cases where the scan tumor cells were admixed with abundant renal tubular cells. Other helpful features that they found, which might increase the diagnostic yield, is the nuclear pleomorphism, binucleated nuclei, and distinct cell border, which may help cleanse the diagnosis of chromophobe RCC. Low-grade clear cell renal cell carcinoma is also another challenging diagnosis during rapid on-site evaluation. In this study, 8 out of 14 cases of low-grade clear cell renal cell carcinoma were undercalled during rapid on-site evaluation. Mostly they were nuclear grade 2 by Furman or the World Health Organization International Society of Urologic Pathologists grading system. Retrospectively, when author evaluated, these low-grade clear cell carcinoma either showed small number of low-grade tumor cell clusters in 3 cases, or naked tumor nuclei in 3 cases, or vacuolated background in 4 cases. Also, sometimes it might be challenging to distinguish the low-grade clear cell RCC from macrophages. Cohesive cell clusters with vacuolated cytoplasm, dark regular nuclei, and prominent nucleoli often may hint at the need of biopsy. Another uncommon benign lesion is angiomyolipoma, which is often challenging to diagnose in rapid on-site evaluation. There are 3 different variants of angiomyolipoma, which are fat rich, fat poor, and fat invisible by radiology. Usually, fat rich is easily distinguishable by radiology and often not biopsied. However, fat poor and fat invisible angiomyolipoma can show overlapping radiologic features with renal cell carcinoma and often require biopsies. 2 out of 5 angiomyolipoma cases were missed in rapid on-site evaluation in this study due to scan cellularity. Retrospectively, when authors evaluated these cases, they identified characteristic features of single or loosely cohesive cell clusters with highly atypical naked nuclei and nucleoli. The cytoplasm of the tumor cells were difficult to appreciate and appeared either stripped or stringy. Sometimes a nuclear atypia of angiomyolipoma may be so pronounced that they might mimic another malignant processes like carcinoma, sarcoma, or melanoma. And maybe immunohistochemistry on permanent sections is necessary in some cases to make the diagnosis. So these are some of the representative features of angiomyolipoma. In the first, you can see cohesive cluster with round to oval nuclei. In the second, you are seeing a bare nuclei cluster with again round to oval nuclei with prominent nucleoli in the same. And even in the in the image C, you are seeing the same round to oval naked nuclei. In D, you are seeing significant pleomorphism with anisonucleosis and prominent nucleoli. E is a histologic core biopsy section with a prominent myofibroblastic proliferation and rare adipocytes admixed in between. And F is a immunohistochemical stain system, stain positive for HMB45, nailing the diagnosis of angiomyolipoma. So talking about the limitations of this study, no fine needle aspiration cases was included in the study. The large number of the rapid on-site evaluation interpretation fall into the non-specific category, which was atypical, lesional, or adequate, not otherwise specified. And the authors also discuss about the lack of standard reporting system, including adequacy criteria. Also, they mention about the lack of ultimate accuracy evaluation of core needle biopsies of renal mass lesions by correlating with the resection, radiologic, and the clinical findings. To conclude, percutaneous core needle biopsies of renal mass lesions revealed various types of benign and malignant lesions. Rapid on-site evaluation using touch preps was largely accurate in evaluating specimen adequacy during core needle biopsy of renal mass lesions despite challenges. Renal tubular cells, macrophages, and occasionally urothelial cells were common cause of overdiagnosis. The naked nuclei of angiomyolipomas may either be overlooked when scanned or overinterpreted as malignancy due to pronounced atypia. Attention to the finely vacuolated background in association with atypical epithelial groups with low-grade nuclei may help confirm low-grade renal cell carcinomas. Thank you. This is the end of my talk. Please feel free to reach out to me via email. My email address is swikritiupadhyay@gmail.com. And if anyone wants to follow me in Twitter, my Twitter handle is listed here at Baskora Cytopath. Thank you so much. I hope you enjoyed my talk.